So let's move into our last part. Again, what's the role of a pharmacist? And again, I've been thrusted into this recently, and there's many things we can do, but to keep it very simple, I want to highlight a few things. Order set and guideline development, education to the team, what you can do at the bedside, and helping with disposition. I'm going to spend, again, just a few minutes talking about order set development, because I think from a system standpoint, this is how you get success. When we're looking at the guidelines, you can have a system order set for sickle cell, and something that I've been involved in is a nursing-driven pain pathway. And this is something that's pretty cool. So when looking at your guidelines, we got to start with triage, because a lot of our care for our patients, they're walking in, they're coming via a private vehicle. You want to make sure you identify and start to initiate the sickle cell protocol there. Again, we want to assess our vitals, all those good things, but as we had mentioned before, ESI level is really just the currency of attention you get in the ED. I'm just going to be very plain and straightforward. If I see ESI 5, I may not look at them as closely. If I see an ESI 1 or 2, they're going to get my attention rapidly. So one of the things we have to make sure is we assign these patients the correct ESI level or the acuity level, and we can start to begin a rapid protocol with the goal of getting them their therapy within 30 minutes. Realistically, that's going to be most likely an hour. And that's what I've really pushed for, trying to get it sooner and sooner, because once I analyze our current data, we wasn't even close. The next component is going to be your initial medical encounter and doing all your vitals, doing all these things. But note, you got to go ahead and start to note any treatment they received prior, so that there's a conversation need to happen was what worked well for you. What was your baseline hemoglobin? What's your date and your reaction to your last infusion, and really start to assess if the patient have a documented, individualized sickle cell care plan, because that is, I'm telling you guys, that's the key to getting great care. If that's documented somewhere, I've noticed more likely than not, even if they're going through the motions, they're going to go through the motions doing what works well for you. And I think that's going to be something that we have to make sure. Next component of this is going to be performing target evaluation. So your nurse is going to do a phenomenal job of getting labs in line, we like to call it, and just seeing what's going to be the response of what we're doing, what the type of symptom we're having. And then the big thing I want to focus on is getting that initial pain management. And I'm going to talk about how I've formulated a plan to get patients in the waiting room and that are initially seeing medications quicker. So that's my big thing, is figuring out how can we do that. Again, if you can get IV access, great. Some patients have ports, some patients have different ways to get them things. But there's one thing you want to make sure of, though, because some patients are actually very challenging to get IV access, and you don't want to delay giving medications based off whether or not they will need an ultrasound guided IV and things of that nature. So we want to make sure that's something we talk about, but also making sure you can kind of check for histories of opioid allergy or just instant sensitivities, because we can get some of those things taken care of up front as well. And then I won't dive deep into this, but again, make sure we do your first pain reassessment based off what level their pain was initially, and talk about some of the other components of preventative care. And then once you go through all this, and we're treating our patients and they're fine, we want to confirm that the patient's pain is adequately controlled. This is something that we lax on as well. Some patients just get tired of being there and they leave, and their pain is not controlled as what we need. But this is something we want to definitely dive deeper on. Ordering medications, again, and order prescriptions. This is something that can get missed, and a pharmacist can be heavily involved when it comes to this component, making sure we have something set up to make it easy for our providers to actually send prescriptions. And within an order set or guideline that you're making, you want to make it to where they can schedule an outpatient follow-up as well, and discuss setting up an individualized plan if they don't have one. So that's going to be something that's going to be huge. And want to now, in this current way, we can make sure we're providing naloxone kits. So that's something we want to make sure as well. So what does that look like? I have a few examples here. I didn't want to post our own, but when a patient comes in and based off allergies, things of that nature, the first thing you can do is go ahead and hit them with, again, at least 2 milligrams of hydromorphone or morphine IV or sub-Q, and keyword, and ibuprofen, diphenhydramine for itching, or again, most of what I see now is going to be for nausea as well. So that may be ondansetron or promethazine. All of that can be given all together, and that's going to be where we can go. And then the next step, if that works, reassess the pain soon, go up in your dose and figure out what's going to be the best way to continue to reassess this pain quite frequently. So one thing that I've worked on over the last year is the creation of a nursing-driven pain protocol. And what this does is I made it to where my nursing staff can go and administer certain medications based off their triaging. And this is something that happens quite often where we have patients come in and we want to do something, but based off how full we are in the hospital or how full we are in the ED and bed flow, we just can't get these patients back. And depending on if they assign them the correct ESI, they're definitely not going to get back sooner than some of the other patients, even if we try sometimes. So you want to make sure the first thing we do within this nursing-driven protocol that I made was get your complete set of vitals, document past history of present illness, and perform like a mini physical exam. Again, do the simple things that our nurses do. Then record all the weights, complete the pain assessment, and then screen for exclusion criteria. And that's going to be big. As you guys are creating protocols, you want to make sure pregnant, renal failure, significant cardiovascular disease, all these things that are red flags to give NSAIDs, you want to make sure we exclude those patients. And it's based off a simple questionnaire, a simple questioning that most of our patients don't necessarily have at the initial component, but this is a way to kind of logistics and from a legality standpoint, free yourself from some of the issues that we had. And I've had very in-depth conversations with P&T committee, and they want to know, how can I make sure that patients are not getting harmed from us giving some of these medications that we're going to talk about? So up front, what's going to happen is we have it to where our nursing staff immediately can go and give acetaminophen. Again, either you're giving them 325 tablets, 3 of those, and you want to be able to give ketorolac, whether it's going to be 15 IV if they have an IV, or 30 milligrams IM. If they don't necessarily want anything parenterally, you can just give them acetaminophen and ibuprofen as soon as they come in. So once you're triaging them, they can get those medications and give that to them immediately. So that way we can go ahead and start the process and get the ball rolling. And one thing that this does is twofold. Again, the patient knows they're getting something versus nothing, whether I know we want more, but I think it just depends on your hospital system, whether you can add an opioid as part of this. Again, some people are doing it. That we mentioned, we are doing other, sublingual and intranasal opioids in the waiting room. But again, as an order set that does not have to wait for someone of a provider to see them as of right now, based on simple triaging and exclusion criteria, we can get these patients up front with some of these medications. And then if there's any other adjunctive medications that I know most of my patients need, like ondansetron or promethazine, they can get that as well, and as well as Benadryl. So by the time my patients actually can make it back to the room, these medications has festered for about 30 minutes, and then we can add on the opioids without having to give them all these medications again. And I'm hoping, and the thought pattern is that if we look at this from a system standpoint over hundreds of patients, what we'll see is that patients' pain levels are going to go down acutely. They may get actually reach their maximum analgesia sooner, and these patients will get disposed sooner. And I think most of the people who are responsible for, again, FTE generation that cares about just the metrics that we're meeting is going to be great, because again, we'll hopefully be able to push for getting an analgesic medication within an hour. And this is a realistic thing for us to do, because these medications are readily available, they're safe, they're something that the patients know they're going to get. And I think this is something that we can, okay, I know you're waiting, but we're going to do something for you, and then we can go from there. So part of this plan, again, they're going to reassess, get a full set of vitals, document patient respond to medication, as usual, inform the charge nurse or the ED physician of any particular concern. And then we want to make sure we have patient monitoring every 30 to 60 minutes. Again, all the full things that we need. And if additional medications is needed, a physician assessment is required. And this is something that's going to cover our butts. But I found that as we rolled this out, I was able to get patients medications sooner. And I would interview them and say, hey, how does this work for you? And it's like, initially it was, hey, I didn't want that, but I like to make sure I caveat everything when I'm talking to our patients that this is in addition to what you're already going to get. I don't want you to think that this is going to inhibit you from getting the medication you're traditionally getting, but this is what I can give you right now. And as soon as we have somebody lay eyes on you again, we can go ahead and start our traditional order set with your pain plan and go from there. And lastly, guys, there's a few things that I have here. A role of a pharmacist in managing this. Again, education is going to be key. I ask my team all the time, what do you think about this? See their attitudes and opinions. And I also go on, I provide in-service for them. Do some side discussions to see how things are going. And at the bedside, performing medication histories and getting these medications so that my nursing staff can administer them. And lastly, assisting with dispo. That can be with prescriptions, helping these medications get from all your retail pharmacies to the ED. And if they're getting admitted to the actual hospital, I've always found that nursing staff sometimes have a hard time managing the PCA orders from a administration component, and then our providers typically have a hard time with ordering. So this can really help you dispo these patients a lot quicker. All right, guys. So we're going to wrap up. Again, acute pain crisis in patients with sickle cell disease is really complex disease process, and there is a huge gap between what the guidelines and the reality for patients treated in the ED. Multimodal pain regimens include adequately dosed opioids appear to be the best approach to treating acute pain, and advocate for the best care for your patients, your family members, and everyone that that are sickle cell warriors. So that's really our big takeaways from all of this.